vaccination of vaccination training. So adolescents are the children 10 to 18 years of age. The screen is not moving, sir. Yes. So immune protection, which is actually induced by vaccines given during infancy, wanes over the years. And this leads to higher than expected incidence of vaccine preventable diseases in adolescents and young adults. When the child is as an infant, the parents are very anxious and very cautious and very particular about the immunizations of the baby. But most of the time we see in our OPDs that once the baby reaches 1 year of age, they become a bit relaxed for the vaccination. And after 5 years, they actually forget about the vaccinations. This is one of the reasons where most of the adolescents are here with less vaccinations or unimmunized. So why do these adolescents need vaccinations? The reasons are the following. To protect against diseases that have higher morbidity in adolescents, for example, hepatitis A and varicella. To boost the waning immune responses of certain vaccines which have been administered during infancy or early childhood. For example, measles, mumps, rubella, pertussis, tetanus, and diphtheria. Adolescents also need vaccines to prevent diseases that appear later in adult life, for example, a cervical cancer. As a part of control or elimination projects of some vaccine preventable diseases, such as measles elimination and rubella and congenital rubella syndrome control programs, vaccinations are required for our adolescents. Nowadays, the adolescents travel a lot for further studies and their work, even abroad. At these times, adolescent vaccinations have to be taken care of, and these adolescents have to be properly immunized before they leave. As a catch-up, who missed the previous opportunities also, we need to immunize our adolescents. The adolescent-specific vaccines are Tdap-TD and immune papilloma virus. The Indian Academy of Pediatrics, the Advisory Committee on Vaccines and Immunization for Adolescents, recommends Tdap or TD at the age of 10 years and the HPV vaccine at the age of 9 years. COVID vaccines are 12 years onwards, and Tdap is preferred to TD, followed by repeat TD every 10 years. When we talk of HPV vaccine, 2 doses are recommended at 0 and 6 months when the child is 9 to 14 years of age, or if the child is more than 15 years, 0, 2 and 6 month schedule has to be followed. Many factors determine the speed at which the immunity wanes, such as vaccination schedule and the type of vaccine. Pertussis vaccination in adolescents is of particular interest, as it is known that the humoral and cellular immunities evoked by vaccines tend to wane after some years. And this has been confirmed by the immunological and clinical studies in recent years. In fact, adolescents have become the main cause of spread of pertussis in the community and persistently high incidence of disease in infants. Acellular pertussis vaccine have shown to provide shorter lasting protection than the whole cell vaccines. And the waning of protection has led to increase in the incidence of pertussis in older children as well as adolescents worldwide. And infants who are at the greatest risk of severe disease because they are not fully vaccinated. And the pertussis vaccination in adolescents has many advantages, including significant lowering of the new cases among the vaccinated subjects. A retrospective analysis of pertussis cases reported in the United States between 1990 and 2009 showed that the introduction of diphtheria toxoid and acellular pertussis for the adolescents in 2005 was associated with a decrease in the number of cases in the age group of 11 to 18 years. And it is also expected that the unvaccinated or partially vaccinated infants may benefit from the herd effect due to the reduction of circulation of the pertussis organism in the society. In Australia, where Tdap was administered to all high school children during 2008 and 9 epidemic, there was a decrease in the pertussis case reports involving adolescents and infants aged less than 6 months. Adolescent vaccination is also highly cost effective. Vaccination of all in the age group of 10 to 19 years in United States in 2005 prevented so many cases, millions of cases of pertussis, and also financial saving was there. A detailed account on the pertussis immunization through all ages is available in a recent publication. In India, the incidence of pertussis in adolescents is unknown. And in a recently published article, which was titled Prospective Multinational Surveillance, B. pertussis infection among 10 to 18 years subjects, 8 Asian countries were included, where 200 subjects were from India. And high titers of anti-PT immunoglobulin, more than 62.5, was found in 18% of the subjects. A study was also done in Vellore on 281 subjects, and this also suggested waning immunity and susceptibility to pertussis, which can lead to periodic epidemics in the community. Studies comparing the adverse effect profile of subjects who received Tdap followed by another dose of Tdap or TD after varying intervals revealed that the adverse effect profile was similar in both the groups. The seroprotective levels of antibodies to tetanus and diphtheria were similar in both the groups. Anti-pertussis antibodies declined rapidly after the first year following a Tdap vaccination was found. Thus, a second dose of Tdap is unlikely to have significant public health impact. The anti-pertussis antibodies declined rapidly after the first year. Moreover, Tdap vaccines have an uncertain role in prevention of transmission and in the herd protection. Thus, a second dose is unlikely to have significant public health impact. And there are no published data comparing rates of adverse events among pregnant women who received multiple doses of Tdap and those who received TD. It was found in the end that multiple doses of Tdap during a single pregnancy with those who received a single Tdap dose and additional TD doses for catch-up vaccination, there were no differences in the immunity levels which were found. The conclusion of the Advisory Committee on Immunization Practices says, due to higher cost of Tdap relative to TD and uncertainty about the impact of multiple Tdap doses on pertussis control and transmission, evidence appeared to be insufficient to recommend Tdap to replace TD. So there is no advantage as such in replacing TD with Tdap for the decennial TD booster, tetanus prophylaxis for wound management, and for the additional required doses in the catch-up immunization schedule if a person has received at least one dose of Tdap. So the recommendations would be for the adolescents 11 to 18 years, single dose of Tdap at the age 11 to 12 years, followed by a booster dose of either TD or Tdap every 10 years throughout life. In adults over 19 years who have never received Tdap should get at least one dose of Tdap regardless of the interval since their last tetanus or diphtheria toxoid containing vaccine, followed by a booster dose of TD or Tdap every 10 years throughout life. For the pregnant women, they should receive one dose of Tdap during each pregnancy, irrespective of their history of receiving the vaccines at 27 to 36 week gestation, preferably during the earlier part, although it may be administered at any time during pregnancy. When we consider a case of wound, for the wound management, a tetanus toxoid containing vaccine is indicated if more than 5 years have passed since the last tetanus toxoid containing vaccine in case of contaminated wounds, and 10 years in case of clean wounds. In adolescents of the age group more than 11 years who have not previously received Tdap or whose Tdap history is unknown, Tdap is preferred. First preference. For a pregnant woman, if a tetanus toxoid containing vaccine is indicated, Tdap should be used. And non-pregnant persons with documented previous Tdap, if a tetanus toxoid containing vaccine is indicated for any circumstances, either TD or Tdap can be used. When we talk of the catch-up immunizations, the recommendations say that for children 7 to 18 years, children and adolescents aged 7 years and older, and adults who have never received tetanus containing vaccine or whose vaccination history is unknown should receive the 3-dose series. In this situation, Tdap for dose 1. Following the primary series, booster doses of Td or Tdap should be followed 4 weeks later for dose 2, followed by at least 6 months later by Td or Tdap, given every 10 years thereafter. The vaccination series does not need to be restarted for those with incomplete DTaP or DTWP history, regardless of the time that has elapsed between the doses. Now, if the child is 7 to 9 years, who receives a dose of Tdap as a part of the catch-up series, an adolescent Tdap dose should be administered at the age of 11 to 12 years. And if a Tdap dose is administered in children 10 years or older, it may be counted as the adolescent Tdap dose. DTaP and DDTDAP is not indicated for children aged older than 7 years. And if DTAP or DTWP is administered inadvertently to an incompletely vaccinated child who is 7 to 9 years, this dose should be counted as the Tdap dose of the catch-up series. And the child should again receive an adolescent Tdap dose at 11 to 12 years. Pregnant women. To prevent neonatal tetanus, pregnant women who have completed the childhood schedule should receive a dose of Tdap. And incompletely vaccinated or unvaccinated women should receive at least 2 doses, of which one should be Tdap. If more than 1 dose is needed, then either Td or Tdap can be used. Human papillomavirus in adolescents also deserves special attention, as HPV infection is the most common sexually transmitted infection in humans. HPV is closely associated with the development of various anogenital and oropharyngeal cancers, of which cervical cancer is the most frequent. Most infections are acquired early during adolescence, at the time of initial sexual activities. So the HPV-related diseases are mainly caused by a few types of oncogenic HPV strains, against which 3 vaccines have been developed. The bivalent vaccine, which covers type 16 and 18, the quadrivalent HPV type 6, 11, 16 and 18, and the nonavalent vaccine, which covers type 6, 11, 16, 18, 31, 33, 45, 52 and 58. Extensive trials have shown that all the vaccines are safe and efficacious against the precancerous lesions due to type 16 and 18 of HPV in 90 to 100% of cases. And regarding the time of administration, they should be administered to adolescents before they start to engage in sexual activity. This is because of the fact that HPV vaccines are inactive against the types of HPV which have been previously acquired by a vaccine recipient, and because antibody responses are the highest between the ages of 9 and 15 years. So these vaccines, the recommendations are: the 4-valent HPV is indicated in females from 9 to 45 years of age. For 9 to 14 years, 2-dose schedule, 0 and 6 months. 15 years and above, 3-dose schedule, 0, 2 and 6 months. The nonavalent vaccine, which is given to females and males from 9 to 14 years, 2 doses, 0 to 6 months apart. And 15 to 26 years, females, 3 doses, 0, 2 and 6 months. If we talk of the current status of adolescent immunization, in India, routine immunization given to young children is dismally low. The NFHS Survey 4 shows that only 62% of the children aged 1 to 2 years are fully immunized. And there is also tremendous heterogeneity in state and district levels. And when we talk of the immunization coverage in India, with immunization coverage ranging from 91% in Pondicherry to 35% in Nagaland, it is thus likely that many children reach adolescent period with no or partial immunization. And a large number of adolescents thus are at a greater risk of vaccine preventable diseases, as they are more exposed to infection due to greater mobility. Considering that teenage pregnancy rate is very high in the country, catch-up vaccination program of adolescents, especially girls, not only will protect them but will also have a direct role in protecting the young infants from diseases such as pertussis. So IAP recommendations we will see. In this table, the advisory committee recommendations say for the catch-up vaccines, MMR 2 doses at an interval of 4 to 8 weeks interval, hepatitis B 3 doses 0, 1 and 6 months, hepatitis A 2 doses at 0 and 6 months, varicella 2 doses at 4 to 8 week interval, and HPV vaccine, as we said, 9 to 14 years boys and girls 2 doses 6 months apart, 15 years and older 0, 2 and 6 months. This table shows the recommended vaccine in adolescents in special situations. Influenza vaccine should be given 1 dose every year. Japanese encephalitis vaccine, catch up to 15 years. And the pneumococcal, maximum 2 doses 5 years apart. The schedule for rabies vaccine is 0, 3, 7, 14 and 28 days. So what is needed? Universally, the uptake of vaccines in adolescents is inadequate. And reasons for low vaccine uptake is lack of knowledge about the vaccines which are necessary for the adolescents among providers, parents, and adolescents. Lack of specific adolescent immunization programs. Behavioral attitude of adolescents towards vaccination. Lack of routine adolescent clinics, and thus fewer encounters with the healthcare system. Whenever the child comes with an illness, only the treatment is given, and counseling for the vaccinations should be done regularly in our all OPDs. Missed opportunities for vaccination as visits for minor illness are not utilized for promoting vaccinations. And successful strategies for improving adolescent vaccination rates involve communication of the benefits of vaccination to the general public, presentation of information in an evidence-based and youth-friendly way, and sensitizing the providers with information regarding the vaccinations for adolescents, adolescent-specific immunization programs, having an adolescent-friendly immunization clinic, and utilizing all the missed opportunities. Currently, US is the only country to issue recommendations for adolescent immunization, which is regularly prepared and annually updated since 2005. In India also, in our country, the Adolescent Health AHA pass group has started a new AHA card, which I will show in the end of my presentation. The HPV vaccines routine vaccination, again minimum age 9 years, and the same things are being repeated in this slide. Catch-up vaccination, administer the vaccine series to females at age 13 years through 45 if not previously vaccinated. And administer the second dose 2 months after the first dose, and the third dose 6 months after the first dose, at least 24 weeks after the first dose. This slide says the Advisory Committee on Vaccines and Immunization Practices recommended in adolescents with range. When we consider the age of the child 7 to 10 years, 11 to 12 years, and 13 to 18 years. Tdap, 1 dose in all the age groups. HPV1, we have discussed 2 doses 0 to 6 months after 9 years, 2 doses after 9 years to 14 years, and again 2 doses till 14 years. After 15 years, 3 doses 0, 2 and 6. MMR, complete 2-dose series at least 4 weeks apart. Hepatitis B, 3-dose series should be completed. Hepatitis A, 2-dose series should be completed. Varicella, 2-dose series should be completed. Typhoid conjugate vaccine, single dose. Influenza, single annual dose. Japanese encephalitis, 2 doses at 4 weeks interval, and so on. The pneumococcal vaccine. The pneumococcal conjugate vaccine and the pneumococcal polysaccharide vaccines both are used in certain high-risk group of children. A single dose of PCV may be administered to children aged 6 years through 18 years who have anatomic or functional asplenia, human immunodeficiency syndrome infection, or other immunocompromising conditions, cochlear implant, or cerebral spinal fluid leak. PPSV at least 8 weeks after the last dose of PCV to children aged 2 years or older, again with the underlying medical conditions. A single revaccination with PPSV should be administered after 5 years to children with special conditions like asplenia or an immunocompromising condition. Meningococcal vaccine. Recommended only for certain high-risk group of children during outbreaks, children residing in the endemic zones, and international travelers, including students who are going for study abroad, and travelers to Hajj and Sub-Saharan Africa. The meningococcal conjugate vaccines, quadrivalent, monovalent, and the polysaccharide vaccines, bi and quadrivalent, are licensed in India. But these vaccines are not recommended for routine use. Only in special situations where there is anatomic or functional asplenia, including the sickle cell disease, human immunodeficiency virus infection, persistent component deficiency, complement inhibitor, example the eculizumab, etc. use after primary immunization, one booster every 5 years in cases of persistent risk such as asplenia, otherwise not. Children for whom boosters are recommended because of an ongoing increased risk of meningococcal disease, again those with the complement deficiency, with HIV or asplenia, follow the booster schedule for persons at increased risk. Children for whom boosters are not recommended. Example, a healthy child who received a single dose for travel to a country where meningococcal disease is endemic, administer MEN-ACWY according to the recommended adolescent schedule with dose 1 at the age of 11 to 12 years and dose 2 at the age of 16 years. This is the health card which I was talking about. The AHA chapter of IAP has started this Kishore Mitra chart card, which we are distributing in our OPDs to all the adolescents to keep in track their development, physical development, height, weight, SMR, their adolescent development, the vaccines which should be given, the catch-up vaccination if some vaccine has been left out, vaccinations for the high group, and the phone numbers, the helpline numbers have also been shown in this card which can help our adolescents and their families. These growth charts have been attached to this Kishore Mitra card. The waist circumference, because the incidence of obesity and overweight is increasing among our adolescents, and the anticipatory guidance do's and don'ts have also been shown so that if our adolescents at least read it once and their caretakers read it once, they will take strict care of our adolescents and prevent them from many infections. Thank you.
Thank you, ma'am, for bringing out most important factors and important concepts in field of adolescent vaccination. The continuous strive by pioneers like you are helping many pediatricians, including me, to make a very informed and a very scientific decision. It's always pleasure to learn from you, ma'am. In case there are any questions, please feel free. Uh, if not, ma'am, then we'll close the session in another 5 minutes, ma'am. In case there will be question, we will take it on the group, ma'am.
Yes, sir. We will take it in the group. We'll take it in the group, sir.
Thank you, ma'am.
Thank you.
Take care,
Thank
ma'am.
you so
Thank you,
much, sir.
everyone. Thank you, ma'am.
Thank you.
Take care.